All right. Welcome to the Moweaqua Fire Protection District presentation on notes and guidelines from the March 15th, 2020 MABUS special meeting regarding COVID-19 and our response to it. Please keep in mind that all information provided is in response to a very fluid situation and subject to change at any time. So we're going to go over COVID-19 protocol. One of the best phrases I heard in this meeting was be prepared, not scared. So we're preparing ourselves for what could be a very, very serious situation. Obviously, we're hoping that it is not. So COVID-19 myths or misinformation. There's a lot of opinions and misinformation being spread about the spread and response to COVID-19, mostly on your social media. Use only information provided and vetted from reliable sources, CDC, IDPH, local health departments, things like that, and understand that this virus is and will remain very dangerous, especially to our aging and immunocompromised population as it progresses through the country and throughout the rest of the world. I am sure you have all heard people question statistics that may seem to contradict the actions taken, but rest assured these measures are for the safety and security of our population as a whole and should be followed. On March 15th, MABUS district departments, law enforcement, and county officials met to discuss the IDPH pandemic response plan. It should be noted that all information discussed is valid for Region 3. Moweaqua Fire responds in Region 6, but our district dispatch center is in Region 3. It is expected that Region 6 will adopt similar protocol. If their protocol is different, we will update information to reflect the updates. So first, just some little bullet points from the meeting. The Christian County Emergency Operations Center is open and ready for operations. It is not currently being staffed. Phase 2 EMS plan from the pandemic response plan is active. Those with compromised immune systems are the most at risk. It is our duty to protect this population at all costs. For those without pre-existing conditions, you'll have flu-like symptoms in most cases. Public buildings will continue to be closed as needed, including county buildings if need be. No person in Christian County has yet met the criteria to be tested or tested positive for COVID-19. COVID-19 can be transmittable up to 14 days before you are symptomatic. However, evidence shows that the virus is much more easily transmitted once you are symptomatic. Therefore, all responders should evaluate themselves for symptoms before responding. Flu-like symptoms are almost identical to COVID-19, but any sickness should be considered reason to not respond. Please try to let Chief know if you are self-quarantining due to illness. Also note, Chief Estrada will be exercising extreme caution and not responding unless absolutely needed due to personal reasons. So general guidelines: do not respond to calls if you are sick, like I just said, and all nursing homes are under lockdown per IDPH. So that includes Moweaqua Nursing Home, Moweaqua Retirement Centers under the same guidelines. So responders should be checked for a fever by nursing home staff. My guess is we'll be doing this internally before responding. In the case of COVID-19, the standard for a fever is 100.4 before entering, and you need to wear a mask in the facility. We need to limit the providers to essential staff only. In many cases, this can be one provider. As long as it's not critical, let's try to keep who's out of the building as much as possible. Ensure that a lone provider or providers have a radio to communicate with the others outside should they need to pull more resources in or something like that. All right, the IDPH pandemic response plan. So there is EMS pandemic level 1. This is when a pandemic exists anywhere worldwide. We are past pandemic level 1. This is not the current plan, but there are the next levels of plans include level 1 responses. So continue with unfinished items and planning and preparations. Basically, anything that hasn't happened yet isn't going to happen. Continue surveillance of infectious disease patient calls for service. That's more on a dispatch level. Callers will be asked on every breathing difficulty or unknown sickness if the patient has a fever or cough. Patients will then be screened for a travel history or contact with anyone who has been diagnosed with or potentially exposed to COVID-19. Review the plan and consider implementation of employee screening for symptoms, temperature, and exposure. Basically what we talked about, staying home, don't respond to the call if you show symptoms of any sickness or illness. Implement mandatory personal protection guidelines when responding to possible pandemic patients. These are our PPEs. We're going to talk about these later on. Basically our standard PPEs plus a little bit more. Prepare to manage increased volume of biohazard infectious waste. At this point, they're telling us that our PPEs can be disposed of in normal means. We don't have to treat them as biohazards, but obviously if they have any sort of secretions, blood, any hazmat material on them, we're going to have to treat them as a hazmat item. So EMS pandemic level 2. We are currently at pandemic level 2, but we could easily move to a higher level at any time. All level 1 precautions and controls remain in place. So level 2 is human pandemic cases identified in the region. Obviously, we have cases in surrounding counties directly neighboring ours. So we should expect cases in our counties anytime. At this time, there is no significant impact on the local EMS and medical systems. We will continue level 1 operational changes, wearing a mask of N95 or greater, wearing goggles, gloves, gowns, etc. It is noted that glasses, your standard glasses, are not considered goggles. They do not offer the right protection. You need to wear goggles. Minimize time spent in infectious environments. We'll talk about that a little bit more later on. Minimize the number of people in close contact with the patient. Like I said, if it can be achieved with one provider, send one provider. Do not send 5 guys or even 2 guys if we can do it with one. Increase efforts at personal hygiene and decon. Wash your hands, use hand sanitizer, wash your hands appropriately, wash your face, decon as needed. Decontaminate EMS equipment. These are our Sani wipes, professional Lysol. While bleach and water is not considered officially adequate for this, we were instructed that it is effective and basically better than nothing. So if that's what we have available, if we get to the point in supplies that we don't have it left, that's what we will use. Prepare for the following: implementation of alternative staffing plans, more of a paid department thing. Personnel may be called to report for duty for undefined periods of time. Stations may be used as living quarters. Alternative human and physical resources may be utilized for transportation needs. Basically, that's saying trucks could be repurposed from fire apparatus into non-transport medical trucks or even transport medical trucks. We will talk about that more as well. Plan on increased use of PPE, supplies, and other items. We have to use as sparingly as possible. IDPH has told us they do not have additional resources for us. So what we have on hand is what we have, at least for this time. So resources are basically gold at this point. So we need to be very, very mindful of that. So pandemic level 3, this is the next and final level of the plan. All level 1 and 2 items are still in effect at level 3. So this is human pandemic cases within our EMS system. Human-to-human transmission with increased morbidity and mortality. Overwhelming impact on local EMS and medical systems. So this has overwhelmed the resources we have, which in our county does not take much. Continue implementation of level 1 and level 2 operational changes. Human pandemic has achieved rapid to human transmission with increased morbidity and mortality. Outbreak is causing an overwhelming impact on the EMS and medical systems. Basically, this means you don't necessarily need to come in contact with somebody who has traveled overseas or something like that. It is a community-based transmission at this point. The next thing we're going to talk about is Plan P. Once it gets to level 3, that allows the EMS medical director or their designee to activate Plan P. So Plan P, like I said, can be activated after the activation of level 3 and is truly a last-ditch effort in pandemic response. So in case of pandemic, demand for EMS of all types may reach crisis proportions. In this event, significant adjustments may be necessary in guidelines covering dispatch, response, treatment, and transportation. Plan P provides guidance for the EMS system when and if crisis point is reached. Basically, all of those aspects affect us. Even the dispatch part of it affects us. So that decision will be made by EMS medical director with county health departments. So kind of read over that and see what you think there. So continuing on to Plan P provides direction in many aspects, including aspects we are not currently involved in, which affect us. Emergency communications would really be what doesn't affect, what we are not actively involved in, but does affect us. So call takers will be screening calls for signs and symptoms of COVID-19, including asking qualifying questions. Telephone triage efforts may be enacted to diagnose those suspected of having COVID-19 and direct them to self-quarantine instead of sending EMS resources. Our response calls for service will be different when the call meets the potential for PUI, person under investigation protocol. 911 dispatch will dispatch us to standby at station only and will not give us the address of the call. However, it should be noted the responding ambulance will be dispatched on the same frequency, so the information will still be publicly available on police scanners. The goal here is to keep public knowledge away from the public they don't need. We expect to get questions regarding our non-response, and the region are supposed to be writing something in the form of a press release. If asked, please tell citizens we are doing what we are mandated to do under IDPH guidelines and we cannot do anything beyond what we are mandated to do by public health officials. When we are required to respond, response should be with as few responders as needed to successfully complete the assignment. The goal is to reduce the number of responders exposed to a person under investigation. So when a 911 call is received for a patient who meets criteria as a potential PUI, Moweaqua Fire Department will be paged to respond to station only. We will only respond to the scene at the request of the responding ambulance. Basically, we're moving into kind of a lift assist, assist as needed role here. No more than one truck and 2 providers should go if possible. Obviously, that's situation dependent. The situation may require more than 2 responders. The goal is to reduce the number of potentially exposed as much as possible. Responding to a PUI call, full PPE should be used if available, including an N95 mask, goggles, gloves, and gown. At a minimum, gloves and masks should be worn. One mask can be used by the same provider several times in a 24-hour period. Wipe mask with an alcohol wipe and allow to dry between uses. We may even be using them beyond a 24-hour period in our situation. We need to conserve our resources in these regards as much as possible. Apply a mask to patients identified as symptomatic and apply it over O2 if O2 is indicated for the patient. Only apply O2 basically by protocol right now, and apply a mask over it, whether it is nasal cannula or non-rebreather. Especially a non-rebreather, it will aerolize the droplets, which can cause a much bigger problem for our responders. HEPA filters should only be used on BVMs for PUIs. We do not have HEPA filter equipped BVMs. So alterations should be made to avoid aerosol generating procedures, like I just said. This is nebulizers, not something we use in our scope. Non-rebreathing oxygen masks, which we do, suction units, which we do, and CPAP and BiPAP, which we do not. So COVID-19 is spread through droplet secretions. This means liquid transmitted through sneezes, coughs, etc. It is not naturally airborne. However, by utilizing non-rebreather masks or suction, you can aerolize the droplets, creating an airborne version of the virus. If a non-rebreather is used, place a mask over the non-rebreather device. Suction should be utilized on a PUI if absolutely necessary, but responders should utilize proper PPE and isolate patient secretions as much as possible. Palliative care or end-of-life care will be evaluated under Plan P. Basically, at this stage, we are practicing wartime triage, deciding who has the greatest chance of recovery and the most number of years of quality of life left. This stage is a last-ditch effort and should not be considered as an option at this time. Further progression will have to happen before this happens. So palliative care is the medical approach aimed at optimizing quality of life, mitigating suffering among people with serious complex illnesses, like those that have pre-existing conditions and contract COVID-19. In a pandemic, decisions regarding palliative care may be required at the BLS level in consultation with medical control when medical resources and medical destinations are unavailable. What does this mean? We could, with medical direction, be making the choice on who is transported and who is essentially black tagged in a triage environment. Suspension of non-emergency activity. This is more of a directive towards ambulance resources, so Decatur Ambulance, Assumption, Dunn's, any of those ambulance resources. However, under the guidelines of Plan P, 3 William 16 could become classed as a reserve unit and placed into emergency service, and we need to be prepared to staff and manage that. So if this condition occurs, all non-emergency activity will be suspended until resources are returned to normal operation status. Alpha or non-emergent calls and calls for first responder companies due to extended response time of an ambulance may be suspended. In a pandemic event, EMS response may be altered. If local response capabilities are taxed, the EMS medical director may suspend response to Omega, Alpha, and Bravo calls, basically leaving only the most critical patients to get an ambulance. Reserve units may be placed into service as BLS pandemic response units. These units may be responsible solely for the treatment and transport of patients that are determined to have signs and symptoms of pandemic, in this case COVID-19. So COVID-19 EMS response. In addition, fire apparatus may be converted into emergency medical response vehicles in some situation. EMS calls may take priority over fire rescue calls at some point if required. Our EMS system does contain many parts, and it is our job to ensure that our cog of the machine is working to keep the entire system as efficient as possible. So like I said, ensuring additional units are being placed into service as needed. For us, this may require designated fire apparatus that are not currently medical response as medical response. Ensure that appropriate level EMS plan has been activated at every level. Ensure that hospitals, public health, private EMS, and helicopter rescue services are notified and prepared to respond. Ensure that all EMS staff are contacted or recalled. Personnel may be required to assist with field hospitals, mass vaccination clinics, can't get that one out, to replace staff under quarantine or to place reserve assets into service. We will coordinate with our local EOCs and ensure that non-emergency incidents are redirected to the appropriate triage points. Christian County 911 has advised us that this is the way that this should happen. However, I am uncertain of our dispatchers' ability to do this task along with their others, especially in a crisis situation. They will be inundated. So I am suggesting we also populate our own maps as necessary of the addresses where known quarantines are taking place within our response area. So during response, EMS providers must pay close attention to dispatch information provided, including what is transmitted over active 911. It is the policy of Christian County 911 to not announce a quarantined person over the air. This information will be included in an active 911 response. So I asked the question, what if we do not get an active 911 page, which obviously we all know happens. So personnel from now on should confirm over the air with the dispatcher whether or not an active 911 page was received. If it was not, dispatch will call with a premises alert for an active quarantine at a given location. Should it be necessary, they'll call you on your cell phone. Patient will be advised by dispatch to be waiting outside for EMS arrival if possible. Stay outside with the patient until the responding transport agency arrives. Keep as much distance from the patient as possible and limit the number of responders within 6 feet of the patient. So if possible, if weather conditions allow and everything like that, don't put them in the back of a 3 Williams 16 or any other response vehicle if we can help it. Don't enter their home if we can help it. And again, try to limit the number of responders to 1 to 2. If patient privacy is an issue, have guys holding up sheets, something like that. So CDC response guidelines, these are outside of the pandemic response from IDPH, but EMS clinicians who directly care for a patient with possible COVID-19 infection or who will be in the compartment with the patient should follow standard precautions and use PPE as directed below. Recommended PPE including N95 or higher level respirator or face mask. This is even the terrorist face masks that we have, if it gets down to that. Eye protection goggles or disposable face shield that fully covers the front and sides of the face. Personal eyeglasses and contact lenses are not considered adequate eye protection. A single pair of disposable patient examination gloves. Change gloves if they become torn or contaminated. If you need to wear rescue gloves or firefighting gloves, wear those over a pair of single disposable patient examination gloves. We should also wear a gown if possible, but they should be prioritized for aerosol generating procedures, care activities where splashes and sprays are anticipated, and high contact patient care activities that provide opportunities for transfers of pathogens, such as moving patients onto the stretcher. I would also recommend maybe keeping a change of clothes at the firehouse in these situations so that decon can happen as soon as possible. When the supply chain is restored, fit-tested EMS clinicians should return to the use of respirators for patients with known or suspected COVID-19. So again, on CDC guidelines, drivers, should we be driving either one of our own vehicles with a patient in it or driving an ambulance provided by DAS or another agency? We should wear all recommended PPE after completing patient care and before entering an isolated driver compartment. The driver should remove and dispose of PPE and perform hand hygiene to avoid soiling the compartment. If the transport vehicle does not have an isolated driver compartment, the driver should remove the face shield or goggles, gown, and gloves and perform hand hygiene. A respirator or face mask should continue to be used during transport. This applies to every ambulance I know of in the area, unless they are outfitted specifically with some sort of isolation between the cab and the box. Every ambulance in the area will not be isolated. All personnel should avoid touching their face while working and at all other times, really. On arrival, after a patient is released to the facility, or in our case, released to the transporting ambulance crew, EMS clinicians should remove and discard PPE and perform hand hygiene. Hand sanitizer is great. If soap and water are not available, soap and water is still the best and most effective way of deconning. Used PPE should be discarded in accordance with routine procedures. So these do not need to be treated as hazmat in most situations. So decon and vehicle cleaning. Responders should remove all contaminated PPE as soon as patient care is complete and outside of uncontaminated vehicles if possible. So if you can decon on scene and did not re-enter like 3 Williams 16 during the entire call, do it. If somebody stepped in 3 Williams 16, we are going to have to decon it as well. Remove PPE using standard procedures and dispose of single-use items into a bag. Dispose of it in regular trash. It is not a biohazard. Providers should use hand sanitizer on scene and wash hands and face as soon as practical. In most cases, this is going to be at our return to the station. PPE, unless otherwise exposed, are not considered a biohazard or hazmat waste. Do not touch eyes, nose, and mouth, as they are the best way to transmit the disease. So The following are guidelines from the CDC for cleaning or maintaining EMS transport vehicles and equipment after transporting or being exposed to a PUI. After transporting the patient, leave the rear doors of the transport vehicle open to allow for sufficient air changes to remove potentially infectious particles. The time to complete the transfer of the patient to the receiving facility and complete all documentation should provide sufficient air change. When cleaning the vehicle, EMS clinicians should wear a disposable gown and gloves. A face shield or face mask and goggles should also be worn if splashes or sprays during cleanings are anticipated. Ensure that environmental cleaning and disinfection procedures are followed and consistently and correctly, to include the provision of adequate ventilation when chemicals are in use. Doors should remain open when cleaning the vehicle. Routine cleaning and disinfection procedures using cleaners and waters to pre-clean surface prior to applying an EPA-registered hospital-grade disinfectant, to frequently touch surfaces or objects for appropriate contact times as indicated on the product label, are appropriate for severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, in healthcare settings, including those patient care areas in which aerosol-generating procedures are performed. Products with EPA-approved emerging viral pathogens claims are recommended for use against SARS-CoV-2. Refer to the list external icon on the EPA website for EPA-registered disinfectants that have qualified for use. Clean and disinfect the vehicle in accordance with standard operating procedures. All surfaces that may have come in contact with the patients or contaminated materials during patient care, examples, stretchers, rails, control panels, floors, walls, and work surfaces, should be thoroughly cleaned and disinfected using an EPA-registered hospital-grade disinfectant. Clean and disinfect reusable patient care equipment before use on another patient. Follow standard operating procedures for the containment and disposal of PPE and regulated medical waste. Follow standard operating procedures for containing and laundering used linen. So in conclusion, please reassure the public when asked that we are prepared and reacting appropriately. Please watch what we share as a whole on social media. Do not scare the public unnecessarily, and fact check anything before sharing. The situation is very fluid. Expect several revisions to this plan as the situation evolves, which could be over the next 8 to 10 weeks. In the end, it will be impossible to know if we overreacted or did too much, but it will be quite apparent if we underreacted or did too little. Thank you for taking the time. I look forward to seeing you all on calls, and be as safe as possible. Wash your hands. Thank you.